Welcome to the Sudanese Orthopedic Surgeons Association. SOSA presents the Biomechanics webinar.
بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف الأنبياء والمرسلين على سيدنا محمد صلى الله عليه وسلم وعلى آله وصحبه أجمعين. Hello everyone, I am Dr. Muaz Mustafa, consultant orthopedic and trauma surgery. Today's presentation is hip biomechanics for orthopedics registrars. We will cover functional anatomy, joint reaction forces, and clinical applications. This is what you need to know for the ward, for the clinic, and the operating room. When we look to this slide, when you have a patient coming to you with hip pain due to osteoarthritis or any other cause, we usually advise the patient to carry a cane in the opposite side of the affected hip to reduce his pain. But why and how it's work? To answer this question and others, you need to learn about hip biomechanics. Our learning objectives, okay, we by the end of this talk, we expected all candidates that understand the force that's transmitted through the hip, and how to apply biomechanical principles to hip pathology and surgery, and also to learn and interpret joint reaction force that change with the gait, using of aids and implants. Let us to take some recap about hip anatomy. We know that hip joint is ball and socket joint, composed of acetabulum and femoral head. Acetabulum is composed of three bones, the ilium, ischium, and pubis, that united together at age of approximately at the age of 8 to form the acetabulum. To deep in the socket of the acetabulum, we have the labrum. Okay, also the femoral head is 2/3 sphere with a neck shaft angle of 125 degrees plus minus 5. And also there is many ligaments that support the hip. You know that the hip is one of the most stable joints in our bodies. There is almost many ligaments like ischiofemoral and pubifemoral and iliofemoral ligaments, which is the strongest one, Y ligaments, or ligaments of Bigelow. So we rarely see anterior hip dislocation because the iliofemoral ligaments is one of the strongest ligaments in our body. And also there is a ligamentum teres that's attached to the femoral head. About blood supply, we have the main blood supplies come in adults is from the medial circumflex femoral artery, especially the posterior branch, but also we have anterior circumflex and retronacular artery, neutron arteries, and arteries of the ligamentum teres. So about muscular anatomy, we have many groups like extensors like gluteus maximus and hamstring, which are responsible of about 30 degrees of extension, and abductors like gluteus medius, which is the most important muscle that support the hip, and gluteus minimus and tensor lata, that's responsible about 45 to 50 degrees of abduction. And we have hip flexors like iliopsoas rectus femoris, that's responsible about 90 degrees of hip flexion with extended knee, and up to 130 degrees or 120 degrees with extended knee. And also we have adductors like adductors magnus, brevis, and gracilis, work in the midline that are responsible about 45 to 50 degrees of adduction. So we have also rotators, that short rotators, and obturator internus, also that responsible about a range of motion of 90 degrees of internal external rotation. We're gonna go through some definition, important definition, like Newton's law. We have three Newton's law. The first one is a law of inertia. So when we have no forces or the net forces equal zero, the velocity remains constant. Hip example, when the patient is standing, stays still unless there is muscle act. The second law is the force is equals mass multiplied by acceleration. So faster you walk, the more increase in the force acting in your hip. We talk about joint traction force. The third law, every force has equal force in magnitude and opposite in direction. So F2 equals minus F1. So, okay. Other definitions, the force is pull and push from the object interaction. Vectors, that quantity with direction and magnitude. So the force and velocity are both of them considered as vectors. Torque or moments, the tendency of the force to rotate the body around the axis. So the moment is perpendicular force multiplied by distance. The work that the force acting to accelerate this or to create displacement. So it's the work is equal force multiplied by distance. Here we reach to the most important slide. This is the free body diagram of the hip. This is one of the popular questions in oral exam or viva to ask you to draw free body diagram of the hip. Or it's actually the starting by Trendelenburg gate, or show you one X-rays with hip osteoarthritis, and then the questions go through the hip biomechanics and a free body diagram. Okay, we want to know the force and load that acting around the hip. We know that the hip is class one lever, that we have central fulcrum in the center of hip, center of rotation of the hip here. Actually, we need the pointer. Okay. We have the weight, which is here led by W, or the gravity. The force is in clockwise, and also we have the abductor force here, M. It's anti-clockwise. Okay, it's act on the tip of the greater trochanter. And also we have joint interaction force, which is oblique, come in the center, that marked by R. Okay, and here in the RY is the vertical component of joint reaction force, and MY is a vertical reaction for vertical component of abductor force. Okay. When we have now the moment, in this picture, we have a moment arm of the weight is B, and moment arm of the abductor force is A. Normally, the distance between the hip center and line of gravity is equals from 10 to 12.5 centimeter. And from the abductor, which is from the weight lever arm. But the abductor lever arm is shorter, is 5 to 6 centimeter, which indicate which is considers as a disadvantage because it need more force from the abductor, okay, to reach to the equilibrium. So the Trendelenburg gate comes when there is ineffective abductors in the contralateral side of the hip is dropped. Now, we're gonna go through the calculation of the joint reaction force step by step, okay? As we know, A, as we see in the previous slides, is the abductor lever arm is almost equals 5 centimeters. And also we have B is weight, body weight of the lever arm is almost 12.5 centimeters. And also we have the R, which is the reaction force, is 4 times body weight. How to calculate that? We calculate first the vertical component of abductor's moment, which is equal the abductor force multiplied by abductor's lever arm, M multiplied by A. That's equal B, which is weight, abductor's weight, lever arm, multiplied by weight. So we have A equal 5 and B equal 12.5 centimeters. So by calculation, we have M equals 2.5 body weight. To calculate the vertical component of the joint reaction force, or R, okay, it's equal summation of vectors of M and W, which is called weight and abductor's force. So vertical components of the joint reaction force equals M. We have M here, 2.5 body weight, with plus 1 body weight, it's equal 3.5 body weight. To calculate joint reaction force, we have to go through cosine of the vertical component divided by cosine of 30. That's equal almost 4 times body weight. So I know this kind of calculation is a little bit complicated. So we let us to calculate the joint reaction force by vectors by more simple way. So in average individuals with 60 kg weight, the body weight is equal almost 600 Newton. 600 Newton is you know the force is equals mass multiplied by acceleration. Acceleration of the gravity is almost 9.8 multiplied by 60 is almost 600 Newton. So the body weight here is 600 Newton. But in the single stance, we have to reduce the weight of the limb, which is 1/6 of the body weight. So the remaining is 5/6 body weight of 600 Newton is almost equal 500 Newton. Now, let us to consider the lever arm is for easier calculation of the body weight is 15 centimeter, and also the lever arm of the abductors, hip abductors, is 5 centimeters. To calculate the abductor force, simply, when we have all force work around the hip joint is equal 0, so the M multiplied by the A is equals B multiplied by W. So to calculate M, which is abductor force, is equals 5/6 body weight is 500 multiplied by 15 centimeter, which is the weight lever arm, divided by 5 centimeter, which is abductor lever arm. When we divide 15 over 5 is equal 3. 3 multiplied by 500 is equal 1500 or 1500 newtons. This is abductor force. So now we have abductor force 1500 Newton, and body weight is 500 Newton. Simply, the joint reaction force is summation of both vectors. It's almost equal 2000 Newton. So how the body is adapt or to decrease joint reaction force we have when we have a problem in the hip. Okay, it's a shift the body weight of the affected hip during a stance, so the trunk is lean toward the affected hip to bring the center of weight near to the center of rotation, so that decrease the demand for on the weak or painful abductors. the center of gravity moves closer to the hip joint, abductor's muscle will pull is decreased, so the joint reaction force will decrease and decrease pain. This is how it's work that compensated Trendelenburg. So there we have also Trendelenburg gate that already discussed by my successor, Dr. Muhammad Ali. As we know, that Trendelenburg gate, in through Trendelenburg gate, the pelvis is sagged through the sound side, okay, because the abductors cannot hold the pelvis because of problem in the abductors itself, weak abductors or superior gluteal nerve or supraglottic nerve injury. So the joint reaction force here is normal or increased. Not like in the compensated Trendelenburg that we discussed earlier, that the patient lean trunk over the affected hip to hide the abductor weakness. So what's the cause of Trendelenburg gait? The Trendelenburg gait, we have problems either in the liver, like this plastic hip, or in the forces like abductors, weak abductors, or nerve injury like supraglottic nerve, or problem in the fulcrum itself of the femoral neck fracture, arthritis, or arthroplasty. So what is the mechanism that we use to reduce joint reaction force on the affected hip? We usually advise our patient to carry a cane in the opposite side of the affected hip. So this is reduced abductor muscle pull and decrease moment arm between center of gravity and femoral head. And when we put a 15% pressure of weights or pressure on the cane, it reduces joint reaction force in the contralateral hip by almost 50 up to 60%. So why? When we look at the equilibrium around of the forces around the hip, we have the body weight is work clockwise, and abductors pull work anti-clockwise. So anything that reduce the force in clockwise and increase anti-clockwise, that reduce the joint reaction force, or the force that needed by abductors to reach equilibrium. So when we use cane in the contralateral limb with higher lever arm, it reduces the force that come from the weight. When we will multiply the weight, we reach to equilibrium, multiply the weight by weight lever arm and divided by lever arm of the abductors, the abductor force needed will be less, so the total vectors or joint reaction force will decrease. This is opposite will happen when you use the cane in the ipsilateral affected hip. So what about carrying load? Theoretically, that when you carry load in the affected hip, so ipsilateral side of the affected hip, also this increase the anti-clockwise forces, so it is decreased joint reaction force paradoxically. But when you carry the same weight in the contralateral side, will increase joint reaction force and increase the pain. So how we can modify joint reaction force? We can reduce joint reaction force by using the cane in the contralateral hand, opposite side, reducing joint reaction force by 50 up to 60%. By slower walking speed. How? As you remember the second Newton law, the speed, the force is equal speed, mass multiplied by acceleration. So when the acceleration is increased, the force is increased and joint reaction force is increased. Also by reduced body weight, and also ipsilateral trunk lean, which is compensated Trendelenburg gait with shifting the center of gravity closer to the hip. That's why the patient with hip osteoarthritis normally has a lurch toward their painful side. How joint reaction force is increased clinically by lifting heavy object, actually in the contralateral side, by stair climbing, which is for increasing body weight 4 times, by fast walking or running, by using a cane in the ipsilateral side or carrying load in the contralateral side. So let us to apply that on hip arthroplasty or total hip replacement biomechanics. Okay, we have very important parameters in hip arthroplasty. The first one is the offset. The offset is the distance between the head center to the femoral shaft axis. So the one of the most important parameters that we our goal to restore is the offset, the hip offset, that to reduce abductor tension and make it more functional or more efficient. And also we have to restore the limb length, that because short limb that it might cause instability or Trendelenburg. And also the other parameter is neck osteotomy level. So when we have a short neck, that will increase the offset, and so sorry, with in the long neck, it increase the offset by increasing or decreasing the offset. So we need to use another the device that high offset implants. The other component, which is most important, is the position of the component. Acetabular component is supposed to be 20 up to 40 degrees of inclination. Sorry, for 40 to almost 45 to 50 degrees of inclination, and 15 to 20 degrees of anteversion, which is the safe zone. Also, this is applied about femoral stem, which is also supposed to be 10 to 20 degrees anteversion. Okay, so what's the action that need to decrease joint reaction force in the total hip? We all know about low friction hip design that done by Sir John Charlie. He depend on decreasing joint reaction force in the hip. How he achieved that? Achieved that by medialization of the cup. Actually, every 1 millimeter that reaming or shifting to the medial side, that decrease joint reaction force by 10 times, and also make it more inferior and make it more forward anterior to bring him closer to the center of gravity, which is in front of the S2. All this will reduce joint reaction force. The other thing, bilateralize the GT. We know that Sir John Charlie he has the GT osteotomy approach. Also, he refixed the GT, but in the more lateral, not in the same side. So this make the increase the tension of the abductors and make it more efficient. Okay, so to summarize that, we medialize the cup, lateralize the trochanter, we have the best mechanical advantage, lowest joint reaction force. So there is some deformities in the hip that might affect the joint reaction force, like coxa valga, when we have valgus angle, neck shaft angle is more than 135 degrees. So that decrease the lever arm of the abductor and shortening, that increase the joint reaction force and lead to early osteoarthritis. And also in the coxa vara, we have coxa vara is mean neck shaft angle less than 120 degrees, that abductor's lever arm with lengthening, so it decrease the joint reaction force. But also paradoxically, it can cause pain because of short limb. Also, anteversion and retroversion change contact pressure distribution and cause labral tear and femoral acetabular impingement. So what's the femoral acetabular impingement? We have two types, cam lesion or pincer lesion or mixed. The cam lesion, the head is not fully spherical, the shear force in the chondrolateral junction is very high. So it's abnormal high contact stress in the flexion internal rotation. It will lead to early osteoarthritis. In the pincer type, there is an overcoverage, the linear labral compression, both lead to the altered hip rotation and secondary osteoarthritis. About the hip, the contact stress on the cartilage, we know that stress is equal force divided by area. So osteoarthritis either happen when increasing the force or decreasing the contact area, like in the cam lesion or subluxation. And labrum also sees the joint distributes fluid pressure. Any tear in the labrum also lead to increased stress over the cartilage and lead to early osteoarthritis. About biomechanics of hip fracture, it will discuss in details in the next webinar, inshallah, by the next month. But we will know that femoral neck fracture is failure either in the tension and compression trabeculae, and also interstroke fracture is a load that transmitted through the medial calcar, which is the most important piece that determine the stability of the interstroke fracture. So when we treat interstroke fracture, we have to choose between DHS and femoral or femoral nerve or BFN. Actually, in stable fracture, they have equal result, or in unstable fracture, the BFN is superior. So we have now a case scenario for 65 years old lady with hip osteoarthritis. Body mass index is 34, uses ipsilateral cane and walk with lurch. Okay, any candidate any volunteer? Hello? Hello?
اختار من طرف بس يا معاذ.
ما في حد ما في حد عايز يشارك. خلاص احنا نطرح السؤال ونشوف يعني. اوكي.
I think Yusuf, the joint reaction force is high, so we can reduce it by using of cane in the contralateral side.
هي مكتوبة الإجابات لكن ناخدها هنا. أيوة. carry on. Okay, carry on. Okay, the first question is why we have high joint reaction force. We have many components, as we see in that diagram. We have clockwise and anti-clockwise forces. The clockwise forces, the body mass index, the weight is so high, so increase the joint reaction force. And the cane used in the wrong side, that also increase the joint reaction force. And also we expect that the abductors is weak. And how we reduce this by non-surgical method, and how by surgery. By non-surgical method, as you said, by using a cane in the contralateral side, by reducing weight, by strengthening abductors. Also, by surgical side, we have to do total hip replacement if we expected that she has hip osteoarthritis. So what's the aim in the total hip replacement? So to restore the offset, to restore the length, to put the cup in the proper position is 45 degrees inclination with 20 to 40 degrees introversion, okay? And also we medialize the cup, make it anterior and lower, and lateralize the GT, which is we have most efficient hip, okay? So this is very simple, okay? Let us to take home message. The joint reaction force in the hip is almost 2.5 up to 5 times body weight. So our aim is to minimize it clinically. The abductor function is the key to the normal gait and low joint reaction force. Total hip replacement success depend on restoring the offset, length, and acetabular position. Biomechanics also explain femoral acetabular impingement, coxa valga, and weak gluteal muscles that cause early osteoarthritis. Okay, thank you. Thank you very much.